Hello, my name is Andy Palmer and I'm here today at Cancer Research UK's Cambridge base. It's a wonderful building and it's not far from Adam Brooks Hospital. So today we're going to have a very interesting discussion. We've got a special guest who's come to join us and her name is Yvonne Cartwright, and her role is she's a consultant in palliative care. So today I'm going to be asking her loads of questions and getting lots of information over what palliative care is, what it means, how to access it, and how it supports families as well. And also we're going to be learning about her experience. Welcome.
Hi, thank you for having me.
Okay, so first off, tell us about your experience and how you got involved in palliative care and why you got involved.
So I finished medical school and I think I was very clear that I was a medic, not a surgeon. Anyone who's seen my handwriting or my sewing will be very glad about that. But I was interested in all the bits of the body rather than a specific bit. And as I went through general medical jobs and then worked in oncology, I realised that the thing that fascinated me was the interface between the patient and their disease and their family, how it affected their body, what symptoms they had and what could be done to improve things, and then how you could make that whole process better and easier for them and their family. So I'm fascinated by pain and other symptoms and how we improve them, but also how we help people to live as fully as possible until they die. One of the founding pioneers of palliative medicine was a lady called Cicely Saunders, and she qualified as a nurse and a social worker before qualifying as a doctor. And she felt that people who were dying needed to know that they mattered right to the end of their life, and they mattered because of who they were, and that everything that we did to try and improve the quality of life for them and their families was really important. And she's been quite a big inspiration. That and the patients I've worked with and the colleagues I've worked with.
Thank you so much for sharing. You must have helped so many families. It must be a really rewarding job.
Yeah, it is. It is rewarding. I think it's also really hard because we're quite commonly meeting people at the hardest moments in their life. But you hope that by being there and by using your skills and abilities, you make it less awful. And I'm really lucky to work in a team of very passionate people who do that. And some of them are in the palliative care team, but actually I have a lot of team members in other teams in the hospital who really prioritise the care that those patients receive towards the end of their life. And I feel very lucky to be working alongside a lot of them.
Thank you. So, palliative care and end-of-life care, these two different types, what are they and how are they different?
So the word palliative comes from the word to cloak, and the WHO describes it as an approach which, instead of trying to cure or change a disease, is trying to minimise the symptoms from that disease or its treatment. So that will involve managing symptoms like breathlessness, pain, fatigue, anxiety, and also supporting patients and their families. End-of-life care, the NHS refers to the end of life as the last year of someone's life and talks about that need to acknowledge what's happening, allow that patient to plan and think about what would be important for them and to provide that support system. I think palliative care is appropriate at any stage of a potentially incurable illness, and the time to start palliative care is when we can make a difference to that patient's quality of life.
Okay, so how do the medical teams decide, okay, now is the right time to start the palliative care process?
I think it varies. So in cancer, there are specific indicators that suggest that palliative care might be helpful for a patient. So if the team that's primarily looking after them, which might be their GP in the community, might be an oncology team in hospital, think that the symptoms they have, they need extra help to manage them. So the common reasons we might get involved are if pain or nausea are difficult. For other conditions, There are also specific indicators. For example, I look after patients with kidney disease, and if they can't tolerate haemodialysis, or if they decide that that's a treatment they don't want, that's quite a common trigger to think about palliative care involvement. So it will vary. But I think if people have an incurable illness and they're deteriorating despite that condition being optimised and treated as well as possible, then the question is, okay, what else can be done to improve their quality of life? And it isn't just palliative care teams that would do that. So GPs do a huge amount of palliative care, as do geriatricians, as do oncologists, haematologists and other teams within the hospital. And we get involved when they need a bit more help to do that.
So, if, for example, somebody had cancer and they were receiving treatment and it seemed like they were on the up and they were improving and it was going well, but at the same time they were suffering from pain and nausea and maybe a cough, would palliative care still be used?
Yes, absolutely fine. We know that the interventions we provide help people to tolerate their anti-cancer treatment longer, and in certain situations may improve people's life expectancy, but we work alongside people. It probably is that the interventions from specialist palliative care need to be delivered for about 3 months for patients to get the maximum benefit from them. And we find that most cancer patients will get about a month of specialist palliative care, and patients without cancer tend to get 2 weeks. So people are missing out on an intervention that could really help them.
I feel like I've been wrong in the past actually looking back, because that word palliative, in my mind, it always meant someone would be reaching the end of their life for sure, but apparently not. You can still carry on living with palliative care.
Yeah. So I think there's a lot of misperceptions about palliative care, and I think commonly for patients it's associated with diminished choice, diminished care and diminished hope. And although unfortunately most of our evidence is based on people with incurable illness, we're not us being involved isn't a sign that time is short or that things are going badly. We should be involved if we can be helpful. And I think all of us working in the specialty want people to be able to access us as early as they need to.
Okay, so let's say, for example, somebody needs palliative care. For example, they're suffering with some pain. Your team, what do they do exactly to provide treatment and to provide support?
So it depends what the cause of the pain is, and normally by the time my team gets involved, someone has already done some pretty significant thinking about what the cause of the symptom is and what could be done. And some of that will be disease modifying treatment and some of that won't be. And they might have tried some, for example, for pain, for some simple analgesics to see if they work, and they would ask us to come and review that and maybe think about other things. So we might think about different types of medications. Those medications might be simple painkillers like paracetamol, anti-inflammatory medications like diclofenac and ibuprofen, the weak opioids, codeine, less commonly tramadol, and then morphine, different types of morphine. And then we might think about how we give those medications. So giving them orally and regular is usually better, particularly to get on top of cancer pain, but sometimes we need to give things via a patch, via an injection, via a pump, etc. But we're always building on what someone else has done and then trying to optimise it, minimise the symptoms for the patient and maximise the gain they get from those interventions.
Thank you for explaining that. It's very enlightening. So palliative care, do you have to be in hospital or can you receive that at home, or both? And also, it's surprising to me when you said that paracetamol, that's a drug which is used in palliative care, because it seems like just a normal everyday medication.
Yeah, so I think most palliative care happens at home. GPs do a huge amount, community palliative care teams will do a lot, district nurses do a huge amount for our group of patients. So we would expect most things to be done at home. obviously depending on complexity of symptoms and what else is going on for a patient. So I work in a hospital team, so we quite often see people who have come in unwell, and that may be related to the terminal illness that they have, but it may not be. But also patients receive care in nursing homes, in hospices, and in their own homes.
It's very broad, isn't it? Different locations. So do you have to visit people yourself and your team? I guess you're quite busy visiting people all over the place.
So in some parts of the country, teams will work across different settings, and in some parts of the country, teams work in a specific setting. So the team that I work with most days of the week, and I work with the best team of clinical nurse specialists in the world, we work just in the hospital. But when I'm on call, I cover the team working at Papworth Hospital, I cover the inpatient unit at Arthur Rank, I provide support to the nurses from Arthur Rank going out to see patients in their own homes, and I also provide advice to GPs going out to see patients at home. So I sometimes have weekends where it doesn't feel very busy and I check my phone and make sure it's still working, and then I sometimes have weekends where my phone doesn't really stop.
You're a busy woman, obviously. Thank you for your service to the community. So, explain the process to me. Right at the start, the initial assessment or referral for palliative care, and then what's the next steps?
So generally we'll get referrals in the hospital from hospital teams, and they will complete an electronic form saying what they need us for. So is it for symptom control? Is it for psychological support? Is it to plan someone's discharge from hospital? Is it to support a family? And those referrals, those are the main things we get referred for. And those referrals can come to a hospital team, to a community team from a GP or a district nurse. And they can be referrals requesting that someone comes out to see a patient, or that a patient comes in somewhere for a clinic appointment, or that a patient is admitted somewhere like a hospice. And what will generally happen is the person receiving the referral will try and get as much information as they can, speak to the referrer and try and work out who the most appropriate person is to go and see that patient, how quickly they need to go, and what else can be done in the interim. So for example, if we get a referral from an oncologist about managing a patient's cancer, Pain will look at their latest investigations, their x-rays or CT scans and their blood tests. We'll look at the medications they're on already, and we might suggest changes that can be done while they're waiting for us to go and meet them face to face. The other thing that we like to happen is we like the team that the patient knows to have explained that they've asked us to come and see them and why they've asked us to come and see them, because we like them to be prepared before we walk in the door.
Seems that to some people the word palliative care, when they hear that word, they can panic and get really worried.
And it's really sad when that happens, because I think sometimes that really does put people off accessing the help that they need. And frequently I've had people saying, oh wow, I could have done with this months ago, but I was just too scared to accept the offer of a referral. And there's clearly work that needs to be done at a societal level to explain to people what palliative care is, so that we talk more openly about death and dying, and we make that easier for people. There's currently a Royal Commission on palliative and end-of-life care, so our MPs are thinking very carefully about what needs to happen, and hopefully that will lead to some really good discussions.
So you told us about palliative care and how that supports families. Also, you mentioned psychological support. So let's talk about families. How does it support families?
So most patients' priorities are to have their symptoms managed as well as possible and to have as little burden on their families as possible. And I think so often the thing that upsets families is seeing patients in distress. So the first thing that we do is try and manage that. But I hope that because of the way we approach patients and the time that we have for them, we're able to explain things, we're able to explain to families how they get help and how they access it, and hopefully we can reduce some of the anxieties. I think also we can provide a safe place for them to talk about their fears and worries, and we encourage people to talk to each other. Otherwise you can have a situation where everyone's too scared and is protecting the other people that are close to them, but that just means everyone's worrying on their own. And actually encouraging people to talk to their loved ones about what matters and what's worrying them is often really helpful. Some palliative care teams do a lot of work supporting people after someone's died and helping them reintegrate back into their life. And there's other things that have been shown to be really helpful. But I think often it's about explaining what's going on and making sure that people know where they can get help when they need it.
It's so difficult for the families, you know, how to cope and how to share their emotions and feelings. It must be so difficult. I imagine that the families are so worried they might sometimes not want to talk about how they feel. Okay, so now let's focus on psychological support for the individual, for the patient. What's that about?
Often it's just space to talk about what's worrying them and being able to talk to someone who won't be surprised by anything they say, who won't be wanting to run away when they're talking about things that might be really scary or really difficult, and also encouraging them to talk to the people around them and making that a safe and easier thing to do. We do have psychologists working with our team, and approaches like cognitive behavioural therapy can be really helpful, as can mindfulness and those sort of practices. And one of the things that our team has done in Addenbrooke's is use virtual reality to give people a way of coping with difficult procedures, or a way of having a bit of time out from a difficult situation. And those are all things that can be done and can be really helpful.
Palliative care then, the future for palliative care. You mentioned kind of virtual reality systems. Are there any different new treatments that are on the horizon or processes in future?
Yeah, I think kind of we're going to be part of the NHS 10-year plan of moving care from hospital to community, of thinking about prevention rather than cure. Initially I was a bit unsure about where palliative care would fit into that, but actually by improving bereavement outcomes and getting people back to work, we can improve outcomes for families after someone's died. And I think we will be involved in the transition from analogue to digital. So we use electronic patient records. I suspect we'll use artificial intelligence. And I'm also hoping that our symptom control will get more specialised. So at the moment, if I want to start someone on a strong painkiller, I go with one and I see how they get on with it. Whereas in cancer, we look at genetics and blood tests to determine treatments for people. And hopefully, I think we will get to the point of having bespoke treatments for pain and other symptoms based on different patients' biometric and genetic data. I think that would be really exciting. I think also we're going to have to get better at managing multi-morbidity and medical complexity, because patients are getting older, they're living longer with all their different diseases. So as well as managing a cancer, we've got to manage the renal disease that's come alongside that cancer, and the diabetes and the cardiovascular disease. So I think we're going to need to be able to manage complexity more than we have done in the past.
Thank you for all that wonderful information. Is there anything else you'd like to add or say that we've not discussed so far?
I think I just want to say that if you know someone who has cancer or another serious illness, do encourage them to think about whether we can help, because if we can help, it's the right time for us to be involved. And quite commonly, we will have something we can do to improve someone's quality of life. And also we can often signpost to other people and other organisations that can be helpful as well. But we're keen to help people as early as they need that help.
Thank you so much for your sharing your knowledge and experience with everybody in the deaf community today.
Thank you for having me.
Thank you.
Welcome. Thank you very much.